Hi everyone, in this video we'll be talking to Dr. Morten Hoegh. He's a physiotherapist and also a pain researcher. In this video he beautifully explained what pain is and how the pain what I perceive may not be painful to you. He also explained about chronic pain, lower back pain, and also the beautiful research that is happening in the pain field. So listen to it, understand it, and try to utilize it for your own knowledge and also how you perceive pain as. So let me know what you think. Oh, hi everyone. Today we have Dr. Morten Høgh, who is a assistant professor at Aalborg University, Denmark. He is a researcher in pain, a trained physiotherapist, and my friend. So he will explain today about pain and also, its implications and everything. So Morten, please introduce and then we dwell into the pain.
Well, thank you first of all for having me. I'm always happy to talk about pain. It's of course the topic that I'm most interested in when it comes to professional life. And I have had quite a long journey into pain. I started, as you said, with being in the clinic, working with patients, and having this sort of really crystallized idea that pain was always caused by something, and by removing that something, the pain would go away. Of course, we now know that that's not the case, although in some instances there are, of course, things that we can change. But in many cases, pain is better to perceive it as an experience with lots of factors. So the question is, of course, how do you get to look into that, because it's such a big area of expertise. And my path was, as I said, starting in the clinic. Then I attended King's College in London for a master's program on pain science. Okay. And then I went back to the clinic, and from there I went in to do my PhD in neuroscience with an emphasis or focus on pain, of course. And then I've continued to do a little bit of clinical work alongside my teaching, my education, or my part as an educator at university, and of course the research there.
Ah, that's amazing. So normally when people take this, this vocational courses, we call vocational, where the vocation, like the profession is set, like physiotherapist remains physiotherapist, or a X-ray radiologist remains X-ray radiologist. But you went into research. This is amazing for me. That's great.
Yeah, I think it's necessary, and of course, it's a weird profession. Physios, lots of physiotherapists across the world, and all with different degrees of education. I think the majority of all educations today will apply to a evidence-based approach, so using evidence and clinical experience and patient preferences to guide treatment. But still, within that framework, there's still quite a lot of variability, and definitely, I'm sort of alluding to be part of the leg, you could say, that turns out and looks more into how can we work more on a scientific approach, not necessarily natural sciences. It could equally well be other sciences, but having this sort of quite scientific approach to it, rather than the more alternative working with sort of the feeling and gut feeling and intuition alone. So I guess there are several schools between those two.
Okay. So Martin, like before we dwell into the subject, maybe can you simply put it in terms, what is pain?
Pain, the easiest way to say it is that pain, you're probably never in doubt when you feel it. You shouldn't be. I mean, unless for some reason it would be the first time you have it. Otherwise, we all have acquaintances with pain, and that's what pain is. So it's something you experience. Pain is always experienced by someone. Just like taste is, just like hunger is, just like thirst is, just like sadness is. It's always experienced by someone. So in technical terms, pain is a perception. Some would argue it's a sensation. That's a bit of a philosophical discussion there, but it's one of the two at least. So it's something that we perceive or something that we experience.
As an experience, and mostly it's a negative experience, right? Pain.
It would be for many, because you could say if the same stimulus didn't lead to a negative or adverse event or an adverse feeling, then it wouldn't be painful, because painful is by definition something that you dislike.
Yeah, okay, yeah. And there are multiple pains and also not my pain is painful to you or your pain is not painful to me. It's complete.
Yeah, and that's true, but it's still, you know, the same way as we see red, we would all agree that the color red is red, and I think the majority of people would agree that when you hurt yourself, let's say you get injured on your hand, that's the feeling that we know as pain. And even if you have that feeling in the absence of an injury, it's still pain.
Yeah.
But if you can't explain it through an injury, then it turns out it's actually much more difficult to explain it. So that's why I think that the majority of all people either implicitly or explicitly think or say that pain is caused by an injury because that's how it feels. So, for instance, in sports medicine, the use of the word injury covers both when tissues have been damaged, but also when there is pain in the absence of tissue damage. So an injury for an athlete might be the feeling of not being able to do their job, as it were, whether that be because of pain alone or because of pain and injury, or even because of injury without pain, is really not specified. So that's one of the semantics that I and others are trying to bring to attention, that pain can easily be there without actually having any damage to the bodily tissues, without any pathology. But at the same time, that especially if you are a clinician, when someone has pain, you need to rule out that that pain is actually caused by a pathology or caused by an injury. And that's sort of the spectrum that we work in. Take low back pain, for instance. The consensus is that 80 to maybe 95% of all low back pain is what we consider to be non-specific, meaning that we don't know what causes it, and we think that it's not a single cause. So there might be several causes, and they might actually be interrelating, so that even if you change one, the other ones might still be sufficient to generate this experience of pain. So quite complex if we want to understand it at a philosophical or even technical level.
Okay, okay. And also I mean, in pain research, we study there are two types of pains, right? Acute pain and chronic pain. And maybe can you elaborate a bit more about that?
Yeah, that's a fantastic question. I would love to discuss that, because acute pain, what is that? I mean, essentially it's pain that goes away. So you can't. So every pain, let's just say the first time someone experiences pain, that in 5 years' time is diagnosed as fibromyalgia, then they had acute pain in the beginning as well. So acute pain is probably best conceived as pain that you would expect to go away again. And the majority of acute pain is traumatic or nociceptive, you could say. So there's an instance leading to this experience of pain, or at least that's how we perceive it. So let's say I bend forward, I have an acute onset of low back pain, but we all have that, and in 99 point whatever 3% of the time, the pain goes away again within the next few weeks, maybe even shorter than that. So in that case, once it's gone, you could say that was an acute episode of pain. Then chronic pain has been perceived as something that doesn't go away, when in fact it seems that the majority of pain will be sort of recurring. So you would have low back pain and then it goes away, and then you have low back pain and it goes away. So are they separate acute instances or onsets of pain, or are they part of a long-lasting or persistent chronic condition? That's probably where the researchers are now sort of agreeing that low back pain, for instance, for the vast majority of all people, is a chronic, non-specific condition that may or may not lead to disability or emotional distress and things that are, for some people, the sort of thing that maybe seem to make pain a big problem for them, when for others they can have back pain and do their work and just be with their back pain. And it will be wrong to say that some people are strong, that's why they can handle it, and some are weak, that's why they can't. Chances are that we are affected differently by so many factors, and it's completely impossible to say why some people have agency over their pain and some need help to gain that agency over their pain.
Oh, this is fascinating, right? I mean, especially in this COVID era, mean, many people are sitting like myself. I do all online work and everything with the computer, and I get lower back pain, and it's I feel only some days, and other days I don't feel. Now I know the answer why it is, because there could be many reasons. It could be sleep, like how long I sleep. It could be the posture, the food what I eat, the weather outside, the mood,
Precisely.
Yeah.
And the best thing you can do is maybe experiment and find out what to do. If I mean, even if you want, some people, just don't care as long as they know it's not dangerous. They're happy with their back pain. They would rather have back pain than, for instance, do exercise. It turns out that if you want to prolong the periods between onsets of low back pain, actually exercise and some knowledge about what pain is seems to be the best thing you can do. But I mean, even if you don't, it's just, if you don't, if it doesn't bother you, I mean, you wouldn't go to the doctor and ask for tablets if all you have is a bit of bad mood once in a while. So why would you with low back pain? And I think we have this construct of back pain being dangerous, and even this idea of a herniated disc, that's sort of the holy grail of low back pain, when in fact it's just an acute injury to the back and it will cure itself. And in almost all cases, the damage to the disc is going to be fine. It's going to be absolutely as it was before, almost. But some people will keep having that pain, which they had when they had a herniated disc, and they start associating the pain with the herniated disc. So whenever the pain gets worse, they think the herniated disc has gotten worse. And that might lead into a negative cycle of trying to find that one thing that can cure your pain, which, I mean, not even at a research level, not even if we could control everything about a person or group of people, we can't even decide who has low back pain and who doesn't, let alone treat those who have it versus those who don't get a specific treatment. So we really don't know much about it other than it's benign for the vast majority of cases, and the pain goes away, but it usually has this sort of periodic trajectory over a period of maybe years.
And also, it's also surprising sometimes now, since I am talking about pain and I'm observing my back, how it feels. Otherwise, I don't care. When I observe it, I have pain. When I don't observe it, I mean, I just go on. So
Yep,
there's sense of consciousness involved in brain, like you are conscious of being painful and you feel it.
absolutely. And that's exactly why also some of the most recommended treatments would include treatments that address your attention. So you could distract yourself by watching this YouTube channel, or you can, listen to podcasts, you can listen to an audiobook, you can watch Netflix, whatever. So these are things that are designed to distract you. They are designed to take up your attention. And the sort of ground theory in some aspects of consciousness anyways would be that you can only be attending to one thing at a time. So whenever you're not attending to your back, it won't hurt because you need attention to hurt in your back. So by distracting yourself, you can actually distract yourself from the pain as well. And some people would say, but what if something is wrong in my back? And I say, of course you need to. That's the first step of all clinical encounters with people with new back pain, is to make sure that we know what's not wrong with them. So the good question would be to your doctor or your physio or chiropractor, osteopath, whoever you'd see, what is not wrong with me? Can you make sure what's not wrong with me? Because that's something we can do. Whereas if you ask, why do I hurt? Well, that is blowing in the wind. We literally do not know.
Oh, wow.
Although you might get a good explanation.
You have a hard life, like when the patient comes to you and asks, like, why am I getting pain? Is it because I have bad
Yeah.
genetics?
And you know what? Most people would like to have a diagnosis, but maybe in fact what they are really asking is an explanation. And although we don't know why they have pain, we can still explain it. And one of the things that I do with my patients is to listen to their story. Because let's say, I don't know how long you've had your back pain for, but let's say you had it for 3 months or more, then you will have 3 months of experience with your back pain that I don't have.
Yeah.
So I can only tap into your knowledge, use you as an expert by interviewing you, by having you tell me, how does it feel? When does it become better? And I use my expertise to design the questions and get the answers, so that, I'm sort of pulling the answers out of you, and then we will hang them up on a string and show you. And that string is what we call a theory. And sometimes, you have back pain whenever you sit. It's worse if you sit long. It's better if you support your back. And an explanation could be, well, your muscles are tired. That's why you like to relax your back. And that's why it stops hurting when you slump or relax your back. And we know that cannot be the explanation for low back pain, but it doesn't matter, because it makes your back pain go away. So as long as you're having this non-specific, maybe persistent low back pain, we really don't need to know why it's there, if we can just find things that can help you get rid of it. And I mean, yeah, imagine you can imagine a dozen things in life. I know as a scientist, what we want to do is understand it, and then we can build it from scratch and reverse engineer something, and then go back into it and find out how to maybe improve it over time. But in the clinical setting, what people really need is to know, how do I get on with my life from where I am?
Oh wow, you're combining both the elements, right? Like you kind of you try to give a quick fix, but in the lab you go and really identify what could be a permanent solution, right?
Yeah.
So
Yeah, and I mean, I would always try and give my patients a quick fix if possible. But again, that's where the scientist comes in and say, have you tried to have any treatment before? And the majority have tried, 10 or 15 different types of treatment.
oh
And evidence would then tell us that it's probably unlikely that another episode of whatever, manual therapy, exercise, whatever, is going to cure your pain. So at that point, that's when we would, coming back to your initial question, that's when we would probably say, hasn't this been going on for so long that it's more likely that it will keep going in a pattern rather than disappear, by the sheer forces or whatever it is that you apply to another person during exercise or manual therapy or whatever, or even medicine. I mean, that's the interesting bit, is that medicine doesn't seem to be, any better at helping people getting rid of their pain. Maybe here now, but usually if you take strong medications, you also have an increased risk of adverse events. So it's more, playing on two horses. How much gain are you getting versus how much of the negatives can you take? Whereas if you go for the more conventional, non-pharmacological treatments, adverse events are quite rare, but also usually you need to do a lot more work yourself. For instance, exercise versus taking a tablet. It's much easier to eat a tablet, but you need to stand, the side effects. But if you compare them, and actually we don't have any studies that really compares them eye to eye, so I don't have any evidence for this, but it's my clear understanding that we wouldn't actually see that, for instance, low back pain over a period of 12 months would be any better from medication versus non-pharmacological treatment.
oh there are no studies like that.
There are no eye-to-eye comparisons. There are very, very few randomized controlled trials looking at, for instance, one type of, let's say, manual therapy and NSAIDs. And you might have some, but the majority of pharmacological studies, they will be looking into either one type of pharmacological treatment, let's say opioid versus sham or placebo, or you might have two types, so the common type and then the new type of medicine, maybe even with the third arm using placebo, possibly a fourth arm not getting anything. And that's how they're designed. But usually you don't compare to non-pharmacological treatwide, which is interesting, because they're on the top of all the recommendations. So worldwide, the recommendations for treating, for instance, low back pain include being active, advice to do all you can, try not to lose whatever you can do in your everyday life, and then understand what pain is, and then start using exercise and perhaps applying some of these cognitive behavioral techniques that we talked about earlier.
Oh, wow, fascinating. So let's go into a bit of science, because 2021 we saw Nobel Prizes for pain research, and also mechanosensitization. It's fascinating. So maybe we start with nociception. So because
Yeah.
in pain research we don't really use pain, we use nociception, right? So
That's true. Yeah, and actually most people are not aware of that. So what we do is we trigger the nervous system to send nerve signals to the brain, and then some magic happens and the person hurts. But interestingly, we can use nociception quite so with quite a small variability. So whenever we use it, we can make people hurt as long as we stay within the boundaries of ethics. We have a very good model applying what you call nociception or a stimulus that can be nociceptive, and that leads to pain. And then what we can do is we can do different models, we call them. So you can perhaps inject capsaicin or chili and activate the TRPV1 receptor you mentioned for the Nobel Prize, the one that just won the Nobel Prize this year. And that will lead to a transient, so a short period of burning hot-ish pain. But more than that, it would also give some sort of, if you use a sufficient dose, you can see that the patient will have, or the person you're testing will have different responses. So even outside of the area where you've added capsaicin, they will start to have a feeling of pain when you poke the skin around the area. We call it secondary hypogeusia. And these are suggestive of changes, modulation we call it, not only in the periphery where the injury or the capsaicin is, but also at a spinal cord level and perhaps even at higher levels of the central nervous system. So basically, when we study pain, we have these three very broad concepts of sensitization in the periphery, in the peripheral nervous system, and sensitization in the central nervous system, maybe at a dorsal horn level, maybe different levels. And then finally, we have this descending modulatory system, which can be, so it's signals coming from the brain and going down to the dorsal horn of the brain, the spinal cord, and that can either turn up or increase the amount of nociception, perhaps pain as well, or turn it down. So that's sort of the three big ones in pain research, and under each of them there will be a range of different things. Sorry, what was that?
That happens in few milliseconds.
It can happen really quick. Yeah, I mean everyone's probably I mean if we sat in the same room, which I would love to, and maybe we had a bowl of chilies in front of us, I wouldn't have the strongest ones, but you could probably do it. But if we had a really strong chili, one that neither of us were used to eating, then just eating it within seconds, we would start to have this feeling of burning mouth, and then you can feel the spread of it. You might even see flare in the throat and the hiccup starting. So all of these are responses that are directly related to this modulatory system we talked about just before. And interestingly enough, they're also transient. So give it whatever 10 minutes and it'll blow off again, depending of course on how much capsaicin was in the chili. But
yeah, chilies are amazing. I don't know why we eat, but I mean, one of my friend asked me in my village, actually, like he asked me, why do we eat chilies? Because our region in India is so famous for eating chili powder. It's called Rayalaseema, and in movies they project that we eat just chili powder and rice. Just chili powder and rice, and you eat, then you become super emotional, and then you can go and hit others. So
oh,
that's how heroism is being projected in our movies.
okay.
And
Oh, really?
yeah, and the theory that people come up is that you need this emotion to work hard in the fields. So because it's a lot of manual labor, and you need to be highly sensitized to do that. Maybe that's
Yeah,
where the chilies existed, and
maybe.
yeah, I don't know. I mean, so there should be some study to be done.
But it's still more, it's more reasonable than for instance, in the US of A, where they would have Popeye eating spinach, which is not going to give him the same super forces, is it? But it does with Popeye. So maybe chilies is a better At least it's more scientifically
What is
arguable
Popeye?
that it
Popeye,
could
Popeye
actually.
or
Popeye. So it's a cartoon character he
ah,
gets really strong, so he eats chilies and then his muscles grow. Sorry, he eats spinach, but it sounds like almost the same story. He just doesn't go berserk,
okay.
but or into the fields and work. He probably does something else with his powers.
I don't know. We have to look into
And
it. Yeah, correct.
and actually, now you mentioned the Nobel Prize, what is maybe even more novel is so that TRPV1 receptor, which is what we talked about, the chili receptor,
Mhm.
has been known for many years, and we know a lot about it. It's been studied widely. But the other person who shared the Nobel Prize with Julius is I think his last name is Papatoulian, but
Mhm.
I'm saying it very quickly so that nobody knows that I'm saying it wrong.
Mhm.
Pataputian, something like that.
Mhm.
I do apologize if anyone knows how to pronounce it,
Okay.
but he's been looking into this piezo, so piezo ion channel, sorry, channels. Um, there are piezo 1 and piezo 2, and the piezo 2 could actually explain how pressure, for instance,
Mhm.
is transduced, we call it, so changed from pressure, from mechanical energy into action potentials, which are nerve signals in the neurons.
Mhm.
And it sounds ridiculous, but when it comes to nociception, we actually really don't know. So now there's a candidate who's actually gotten the Nobel Prize. So it seems like there's a grand idea out there amongst the high level society scientists
Mhm.
that the piezo 2 is our best go-to theory for how mechanical transduction is done in nociceptors. And if that's the case, then talking about low back pain before, maybe that could lead us to finding out how exactly does the piezo 2 work.
Mhm.
Let's say it does, and it works in the tissues, in the neurons that are relevant for your experience of low back pain.
Mhm.
Then perhaps there would be a tablet at some point that could make that awkward or painful feeling of discomfort in your low back go away simply by taking a tablet,
Mhm.
which currently is unlikely to happen with NSAIDs, for instance, unless your back pain has a specific type, and even less likely with paracetamol,
Mhm.
that clinically doesn't seem to be having any effect at all for low back pain.
Okay. So that means like if pizza 2 is the player and I think it's druggable, right? So you can identify drugs for that and then you take a tablet that affects pizza 2 and and then the pain is
Yeah, I mean, at some point, I assume that's what people who are much smarter than I will start doing. They'll start doing, studying the piezo 2 because I assume that that's the one that would get all the attention now. There's been other like TRPV4, and there's been other receptors, even ASIC receptors. So there's been a range of receptors responsible, thought to be responsible of transducing this mechanical high load stimulus or intense stimulus. But
okay.
I assume that more people now will go into studying the piezo 2. New, animal models will come, and you can do all of the basic research that essentially will lead people to be able to create some sort of pharmacological antagonizing mechanism on the channel, I assume. But
I
we'll
mean
wait and see.
that's a reason Nobel Prize is given, right? So it's kind of I think it's a groundbreaking research and also now there will be a lot of applications and then
Yeah.
also like you said ASICs and other channels, right? So there's a bunch of channels that are in the research in pain and I think do you think that we already identified whatever we need to identify for pain or there's still a lot to do in research in terms of
Yeah, that's obviously there's a lot because we don't know enough. The question is, of course, are we barking up the wrong tree, so to speak? Have we looked long enough for nociception, or and should we start looking at? I mean, you know more about this than I do, but perhaps microRNAs, is that where we should go? Is it more, a pre-genetic thing? Is it is it in a completely different world that we should try and understand it? Maybe try and understand how the cortices, how does the cortex, how does the central nervous system work? Does it work like a computer that creates models of the near future, so predictive models of the future? I mean, now that we have very good models and we understand a lot about the pain that is initiated by either nociception, that could be doing exercise, or it could be having an injury or having a pathology. And then, of course, the pain that is related to having a nerve injury as well, what we call neuropathic pain. So they're the ones that we have really good models and lots of understanding on. And if a patient is suffering from, something that could be explained by either one, they're usually much better understood in the sort of clinical realm as well. Whereas when neither of them can explain, so if you have low back pain and nothing seems to be triggering it, there's a lot of things that does, makes it worse, but it sort of comes out of the blue and it goes away again. That's much more difficult to handle, both from a scientific and also from a clinical perspective, but more so perhaps from a scientific approach, because we can't, we don't have a rat model or a mouse model where we can have them experience spontaneous, uncorrelated pain. We need that, initiating thing, whether that be viruses or bacteria or pathology or even injury, or but we need that insult to the nervous system. So that has spun off a lot of new interest in computational modeling. I would say is probably one of them. But even philosophy, philosophy is working and have been working for many, many years on understanding the complexity of pain. So the sciences related to pain are still, to some extent, looking from a neuroscience perspective. So understanding that there's a difference between the nervous system and the perception, and nobody really understands the gap between. So where does the nervous system stop and where does consciousness start?
Oh my God.
Is consciousness the product of the brain, or isn't it? There's a lot of opinions about that, but there's no. Let's put it very simply said. So if I was if you were in a scanner, you had low back pain. So if you were in a scanner, there would be people who could scan your brain, even see functionally what happens during perhaps your painful episodes, and compare them to how does your brain look when it's when you're not experiencing pain. But even having all that amount of data and not having restrictions in how to get it, it's plausible, it's financial acceptable, it doesn't cause you any side effects. So we can have all the data that we want if we have enough money. But still, even with all that data, we can't really say where does the brain stop and where does consciousness start. So we are at a very theoretical level. So definitely, yes, we need more research.
Yeah, and also the beauty of pain science is that you're much more aligned with the holistic, the philosophy or being a human completely. I am reminded of a story which I read somewhere. There's a saint, there's a monk, obviously, who had who practiced meditation from so many years, and he practiced detaching himself from the body. So in the philosophy of Indian Hinduism, we say that there is something called Drishya Viveka. So what that means is that the eye can't see the eye. The person, like the eye, what is seen is being seen by something else, and even something is seen is observed by someone else. you know when you are asleep, you know that you are asleep. When you are in
Yeah.
dream state, you are in dream state. So it goes into deeper philosophy and says that you are, in the end, you are just a consciousness, and you just need a body to experience it. And this goes deeper in the monks in India. And a monk who was supposed to have a surgery, and then since he is able to detach himself, so he it was a major surgery. I don't know what surgery it was. And then he the anesthesiologist came to do give anesthesia, and the monk said, like, please don't give anesthesia, I don't need it, because I can detach myself, and then you can perform your surgery. So surgery went well and everything. And then after a few days, they have to remove the stitches of the surgery. And the monk again went to the hospital, and they didn't tell that he has to go and detach. So now it's little surgery kind of thing, and the monk was screamed like when they were supposed to see the remove the stitches, and the doctor asked like, "Hey monk, we did a big surgery on you, and you didn't even say anything, and now we are just removing the stitches. You are shouting with pain. So what is that?" And he said like, "Yeah, you didn't tell me to detach myself,
Yeah, exactly.
right?"
I mean, and imagine we could treat, if that we could actually teach people that. Again, from a scientific perspective, we would say that you are activating the descending modulatory system, and that could explain in on a molecular level why is this happening? Why can you do that? But interestingly, as your story says, they can actually do it themselves, so they can turn it on and off.
Yeah.
And I think that's what happens in many conditions as well. And even the opposite could be the case, couldn't it? Where nothing has really happened, but you think that the situation you are in, the context you're in, is extremely dangerous for you, and then you might experience pain even in that benign condition or situation.
Yeah. Like for example, phantom pain, right? Phantom pain is extraordinary. For me, it's miracle, like how the brain functions.
Yeah,
Yeah.
yeah. And of course there's likely to be many different things at play, because you do have in at least the majority of people, you will have a nerve injury where for instance the arm is missing.
Hmm.
So there could be a range of different changes going on in your body. But the whole pain world is full of wonderful stories about patients. I would refer to patients rather than in your case the monk.
Hmm.
But it's the same story. I mean, they can endure so many things,
Mm.
but usually they won't come to us and say, my problem is I never have pain. um, but if you think of it, on a sort of a spectrum, or even as a cycle, you could say that if there are people like the monk who doesn't have pain, wouldn't it equally be relevant that some are coming into the clinic with pain?
Hmm.
So the monk didn't have pain, but surely had an injury. Could it be that someone comes in and have pain but no injury? Well, of course it can. That's what we see. I mean, that is the majority of musculoskeletal pain today. Low back pain being perhaps the most studied example.
Okay. Okay. Are there any artificial intelligence models that could predict? I mean, now it's an era of machine learning, artificial intelligence, genetics, genomics. So can
I
you make a model
I
of
know
that?
that there is a study that I'm sorry, I can't remember the first author, but it was from Tor Varga's group in Boulder, Colorado. They did some artificial intelligence or learning, deep learning with brain scans, and I can't remember. I think they did it with the narratives of how the patient felt the pain,
Hmm.
and then they looked at how it changed over time. So is one narrative more indicative of long-lasting pain versus another one? I think that's how it went. I can't remember as I'm here, but I know that of course people will be using artificial intelligence,
Mm.
and even something that we are looking into is looking at how satisfied is a patient after having been to treatment.
Mm.
But in order to do that, we need to collect a lot of information. So we have information for more than 50,000 people that
Interesting.
share this information with us, so we can analyze it. And for that, deep learning is, or artificial intelligence is a really good model. But we
Mm.
haven't been we haven't been working on it for long, so we can't really say anything. Not that I won't, I just don't know anything yet. But
Mhm.
obviously, computer modeling, artificial intelligence, all of the developments that are out there, we need to look into them, because as I said, we know so much about nociception.
Mhm.
So keep doing the same thing is probably not going to get us another big leap.
Mm.
Now the piezo 2, that will of course create room for another round of lots of good studies and experiments and knowledge. But I also think we need to approach it from different aspects and different professional backgrounds as well. So, for instance, at Aalborg University, where I did the PhD and where I work now, many of my most esteemed colleagues are engineers.
Mm-hmm.
So they come at pain from a different perspective and have, been creating all these wonderful machinery, for instance, that can help us study pain.
Mm-hmm.
So a lot of different people and different professions, different aspects go into studying pain, and I think more is needed.
Yeah, yeah. I mean, it's interdisciplinary science. It's not just biology. We need to philosophy, theology, and everything. I think has to come into picture. And
Precisely.
yeah. So I mean, I think I can talk whole day with you, with Morten. This is such a fascinating subject. I mean, my PhD was also on chronic pain, cancer pain. So maybe we talk a little bit about other pains as well. Let's say migraine or also one pain that I also feel that it's a especially for the women, like menstrual pain. Every month they get. I feel
Yeah.
that as a man we are privileged not to have that. And when you I mean, I can't talk how a woman feels it, and also during the delivery. I think there has to be something that they could get out of this pain, right? Maybe during the delivery, I'm not sure how it works, but during the menstrual stage, it's a, until, from, let's say, if a girl gets into puberty at 13 or 15, and then going to menopause around 45, it's a monthly pain, like if some for,
Yeah.
let's say, 3 to 5 days or 7 days every month. So, or even migraine patients, it just comes. So what's your take on it?
Well, again, these are now categorized. So it goes for all of these recurrent pains, including the ones you mentioned, that the ICD-11 from the WHO
Mm-hmm.
is now the new classification of diagnoses.
Okay.
And in that, for the first time ever, there are now two parents, they're called. So the top categories, one called chronic primary pain, that would include menstrual pain or even vulvodynia. So they're pains that are unrelated to any known pathology,
Okay.
but they persist. And essentially, in order to get the diagnosis, they also have to have significant influence on functional and emotional lives
Mm-hmm.
in the patient. And then there is the other type of chronic pain, which is then called chronic secondary pain, where you have the pain as before, but on top of that or subsequent to that, you have changes that might be. So again, if it's pelvic pain in women, it could be endometriosis for some girls or women.
Mm-hmm.
They have scar tissue and bleeding that causes inflammation.
Mm-hmm.
But also, in broader populations, including men, you would have osteoarthritis, or you can even have cancer pain, as you mentioned before, or you can even have pain after the treatment for cancer, where the cancer itself maybe wasn't that painful, but then you had surgery, for instance, or chemotherapy or radiation therapy, and that leads to a pain that is then considered, if it goes on and it affects your life and all of that, it's considered a chronic secondary pain.
Okay.
So we understand it, and again, from a very, very mechanistic approach, we would say that pain is either nociceptive, so it is due to a stimulus or something in the peripheral nervous system, or it could be neuropathic, so there's a damage to the nervous system, either central or peripheral.
Okay.
Or it could be what we call nociplastic. So the idea that your nervous system could actually change over time, that could be genetically, but maybe that could be an explanation as to why normal bodies that look healthy, that are, just like everyone else, there's no obvious genetic variations, but people just for some reason have pain. So that's sort of the three mechanistic descriptors, as they're called, that the International Society is promoting to study pain from as a mechanistic approach.
Okay.
Of course, they cannot explain everything, but they're sort of the consensus mechanisms that people would refer to nowadays.
Hmm. And when we say study of pain, are there many researchers working on pain, or you think there's
Oh
still?
yeah, it's a massive field. Yeah,
Okay.
lots and lots of pain studying. Of researchers studying pain, and again from all kinds of backgrounds.
Mm-hmm.
So the World Congress of Pain, or the Pain Congress by the IASP, for instance, or the EFIC, the European Pain Federations. They, thousands of people there. It's it's a it's a it's absolutely big, and most universities, I don't, but most big universities nowadays will have some sort of entrance into studying pain. Some might be studying lower back to understand pain. Some might be studying philosophy to do it. Some might have a socioeconomic perspective on it. But think about, low back pain, for instance. In Denmark, 1 in 5 sick reports is due to low back pain. So
Sick, sick leave.
1 in 5
Yeah.
sick leave, yeah, just for one day. So just absenteeism generally. 1 in 5 is on low back pain.
Oh my God. Okay.
So I mean, Denmark is a really small country, but 9 million kroner, which is an equivalent of let's say 1.5 million, a billion US dollar a year,
Mm-hmm.
is spent only on the money we lose and people not going to work due to low back pain.
Mm-hmm.
So it's massive amounts of money. Imagine a country like India, how many people can't go out and do their work in order to make their lives comfortable, whether that be because they like their work or because they make money out of working or whatever it is.
Mm-hmm.
So there are so many people studying either the direct correlations of why we have pain, or perhaps the sort of secondary problems related to pain.
Okay. I mean, now I want to ask more in terms of career-wise, because most of my YouTube talks are seen by students, and let's say if a bachelor student who is studying biotechnology or biochemistry, if they are I mean, most of them, when they apply for masters or PhDs, people ask for area of your interest. So
Mm.
for many of them, they say cancer biology or neuroscience, but I haven't seen anybody who's talking about pain science, because I think it's not so popular. But
Well, I mean, it's neuroscience essentially, isn't it? So you could go from any aspect of neuroscience and study pain from that same perspective. So usually when you study neuroscience, you're studying either vision or hearing, taste, or sensation or
Mhm,
smell,
mhm,
and pain is simply one of these responses, isn't it? So it's an experience of pain related to your sensory system.
mhm,
So usually you would study the sensory system, but even cognitive neuroscience, they would study the responses of the brain in relation to the perception of happiness or pain or
mhm.
whatever it is. So a lot of neuroscience graduate students could be directly involved in pain research.
Okay. Are there any programs dedicated to neuroscience that people can apply anywhere in the world, let's say in Europe or maybe in Denmark?
I Again, I know of several universities that have programs related to neuroscience. Not all of them directly to pain, but at Aalborg University, again, we have master's programs directing people to study, for instance, industrial medical so it's industrial medicalization. So it's engineering, looking at how to create, for instance, tools or kits that are used to develop either study pain or treat pain.
Mm.
So they have that approach. There's a range of schools looking into cognitive behavioral therapy, cognitive neuroscience,
Mhm, mhm.
which in essence is also neuroscience, but more from a cognitive perspective.
Okay. So, I mean, in terms of Denmark, Morten, since you know very well your ecosystem, you are also in academia. So, if students wants to apply to Denmark, are international students allowed?
Yep.
Yeah. Are you
We have quite a big institute. So the Health Science and Technology Institute is quite big, and CNAP, my former affiliation at the university, Center for Neuroplasticity and Pain, is always looking for good and bright students to develop their skills within pain research.
Okay.
So Professor Thomas Graven Nielsen is the lead of the laboratory, and the group that would be relevant. So he would be the go-to guy. Or of course, if anybody's interested in getting in contact with Thomas and they don't know how to find him, they can always reach out to me.
That's great. That's great. I mean, there are many students who are looking for PhDs or even masters sometimes, or otherwise doing internships. So people like
Yeah.
you are the go-getters. Like you are the ones, like the lamp
And
they can come.
and we have a very broad of a very international group, and Thomas has been really good to get people from abroad and coming to Denmark and Aalborg University. So Aalborg is a small city in most city scale, in the top of so the northern part of Denmark.
Okay.
And it's a wonderful place. Lots of nice people up there. So people usually stay if they can.
You are there. That's why nice people are there.
There are lots of nice people. I'm not sure I'm one of them, but definitely there are many nice people there.
Cool. So Morten, and also I'm a startup guy. Like I love to help startups, and I make courses for them. I train them on multiple things. So when we see this pain is such a big thing, like I think, except if you don't have any genetic abnormalities, that I think we have some channel, right? If you don't have it, you don't feel pain. I don't remember which was its calcium channel or sodium channel.
Yeah. So there is the voltage gated sodium channels along the axons. So some people with mutations, they have congenital analgesia, so they can't, insensitivity to pain, you could call it.
Yeah, exactly. I mean, like that would be a miracle for to make others as well mutated. But no, it's also painful not to feel pain, because imagine if you fell on, let's say, a nails or put it on fire, and you don't feel it and it got burnt, and the
Yeah.
pain as a protector is gone, right?
Yeah.
And
That's true. And speaking of startups, so there's quite again, Aalborg University is quite famous for trying to support startups. So there's a lot of those as well, and many try to come up with, for instance, virtual reality training for people with chronic pain, or they would come up with tools that can be used to register or to measure pain. But I mean, really, we're looking perhaps in the wrong direction. If you were to support someone with a startup, or if I was at least, I wouldn't encourage people to come up with something that can measure pain, because why not just ask the person? I mean, you have the person right there. Why not just ask them?
Yeah.
So it will be so difficult to come up with something, but maybe what would be relevant is to come up with a more complex measurement. So we have been talking about for many years about these PROMs, so patient-reported outcome measures. Usually they would be in form of a questionnaire, for instance. But one of the trickiest things for people with chronic pain, especially the type of chronic pain that is sometimes given the diagnosed fibromyalgia. So if you have this kind of chronic pain where you feel the pain, but nobody can sort of validate it, there's nothing to see on the scans and the blood samples. If someone could come up with a tool that could help, measure a range of things on this person, like counting the steps or using the Apple Watch or something to generate a lot of information that could maybe at some point be used as a biomarker for changes. Maybe not necessarily for measuring the pain. As I said, that's maybe not what we need, but maybe it could be relevant to have an identification of things that you could then go on with a therapist perhaps and identify. Let's say, very simplistically saying that if you know that sitting for more than 60 minutes will increase your low back pain, How would you know that? I mean, it's basically based on a guess. It's like, well, I think maybe 60 minutes. So if someone was to come up with a gadget, maybe that would be the one. So you could easily say, keep notice of when I sit and let me report whether or not I feel pain. And then over a period of 5 days, you could collect much more data than I would be able to help you do if you came into the clinic for 4 times over 4 weeks. So maybe that sort of clarification, structured collection of biometrics could be one interesting avenue. I'm not sure what we will find, but it could definitely be interesting. There's a range of things we don't measure today because
the multiple apps who are doing that, and I also recently saw some of the biotech company who are trying to identify some markers and then treating pain. And of course, there are a lot of drug molecules that are like, let's say, lipoxygenase inhibitors or COX inhibitors. This pain pathway inhibitors, which are very old classic style, which are 60s or 70s. They have been discovered, and we still use the same, right?
But we talked about treatment effect before. So what usually happens when you study, or especially when you look for systematic reviews, you look at all the studies that have used a VAS scale, so 0 to 10 or 0 to 100, and then you usually have some sort of disability questionnaire like Oswestry or Rowland-Morris disability questionnaire, and then you would search out only those studies who have included that. But in essence, I mean, we sort of now know that you can have more or less pain on a VAS scale, or you can have more or less disability. And whilst that is one way to measure it, I'm completely agreeing with that. Just because it works on a group of people, it doesn't mean that this treatment works for my patients, or it doesn't work. So it would be nice to have much more individualized measures that could, feed back information on, maybe to begin with, 200 different things over 24 hours a day for 2 months or whatever, and then you would need that underlying algorithm or artificial intelligence to collect up the things that seems to be correlating with how you feel or when you feel your pain, and then you could train your own sort of PROMs, your own patient reported outcome measure.
Okay.
Which of course would be individualized but also changeable. So if things change, let's say you get some pharmacology that actually helps you sleep better, and that has an increase on your pain, then your whole biometrics should change as well in order for you to get an updated profile. So these are quite fabulous ideas. I think they would be great if we had them, but I'm not sure, first of all, how much they would work, and it does sound a bit sci-fi. But again, we can do things today that we couldn't do yesterday. So
no, the problem with these digital applications is the adherence from the patients. So there's some kind of motivation that you need to go and log in, because what we are talking is preventive medicine. So when they, when you track it, treat it, or maybe prevent it, right? But the thing is, there's a lot of patient involvement, logging in. If, let's say, Apple Watch, let's say I'm sitting 1 hour, now the Apple Watch asks the question, do you feel back pain? Now I need to look, my back is paining, being conscious. Then I feel like, I think I'm a little painful. Otherwise, if the watch didn't ask, maybe I don't care. So it's actually painful to have it, right? Now I feel pain, that's why it can't work. So it's just, there should be something.
And again, I mean, that's a great point. And of course you would have to have inputs that, so you can say, now I have it, when you have it, when you are conscious of it, but also the algorithm should be able to, to prompt you and say, from my calculations, this is when I would expect you to feel pain. Do you agree? And then a yes or a no could help you, redevelop or learn the deep learning bit.
No, fascinating field. I mean, there's a lot happening with the startups.
It's amazing what we can do. But I mean, at some point it would be fantastic to have much more individualized and personalized aspects or measurements of how a person responds to treatment, because what we see is that when we treat the majority of those with chronic pain, the pain is not the thing that really disappears. So it might decrease, and there are good options to lower the pain momentarily, but in the long run, what really works is to make people work despite of the pain. If it's work that's the problem, or function, not controlling the mood. If hurting creates a bad mood, then controlling the mood is much easier than controlling the pain. So there's a range of things we can do now, but they're not easy things, and they set a lot of they demand a lot of resources on the side of the patient. And we are literally, but that goes for all chronic diseases. We say to patients, you need to take care of yourself. That's what chronic diseases is. So it's very similar to diabetes. And I mean, it's easier if you say, by now your blood sugar level demands you to do this action, because it's sort of quite binary. But once you have this complex interaction that might or might not lead to pain, or pain influencing maybe the way you sit or the way you move or breathe, or even the barostatic levels in your body could be affected by pain. So there's so much, and even we don't know if it's one affecting the other. So is it sleep affecting pain, or is it pain affecting sleep? So there's so much studies to be done.
That's amazing. So Morten, I think we can go on forever. There's so much to talk. It's a fascinating field. Maybe some final words and then let's conclude.
Yeah, I think that's a good idea.
Yeah. So is there something that you really want to share about pain? Like how fascinating this field is? You encourage people or patients, anybody, some words you can tell us.
I think the most fascinating thing about pain is to realize, when you really understand that pain is an experience, and it's independent of what goes on. So it's strongly correlated with, for instance, injuries, but you can have exactly the same pain without that injury. And I mean, that has been a fascinating journey for me to come from this very hardcore understanding of a stimulus response system leading to pain, and to this through the philosophies and through the neuroscience of all of that, and ending up on a much more humanistic approach, just really knowing how important it is to understand the person in front of me, even as a researcher, keeping in the back of my head that it would be interesting to do this on a group of people, and then keeping in the back of my head, how will it affect one person? Is it really going to change the world for one person, or am I just doing what has been done so many times before? Are we really answering useful questions for this one person at a time? I think that's fascinating, but also quite difficult. So most of the times we'll have to settle with what we can do rather than what we would want to do.
So the answer is personalized pain therapy, right? That's what your aim is.
Essentially, that's what we need to do in the clinic, isn't it?
Yeah. Great, Morten. So thank you so much.
Thank you for having me, Jagadish.
Sure.
Pleasure.
Hope you enjoyed the video and learned about pain. As it is said, pain is inevitable and suffering is optional. So make sure you learn the science of pain and utilize for your benefit. Thank you.